Okay, imagine this scenario. You're in the intensive care unit. A patient comes in, hemodynamically unstable, classic acute abdomen presentation.
High stakes.
Exactly. The stakes couldn't be higher. In critical care, getting that rapid and accurate diagnosis of bowel pathologies isn't just important, it's genuinely life-saving.
Absolutely.
Yeah.
These are, without a doubt, some of the most challenging and time-sensitive conditions we face.
Mm.
The window for effective intervention can be incredibly narrow,
Yeah.
and missing those subtle cues, well, it can have devastating consequences.
That's why today we're diving deep into 3 interconnected, high-stakes abdominal emergencies you, as an intensivist, will frequently encounter. We're talking colonic ischemia,
Yep.
large bowel obstruction, and we'll put a special focus on volvulus and Ogilvie syndrome within that, and pneumatosis intestinalis.
3 big ones.
We'll explore their, nuanced presentations, dissect their diagnostic pathways, and break down the evidence-based management strategies. And we'll be emphasizing the critical insights needed for effective intervention, especially when every second truly counts.
Our mission today is really to equip you with that deep knowledge needed to navigate these complex cases with, hopefully, greater confidence and precision. We'll begin by dissecting colonic ischemia, examining its epidemiology, its incredibly variable clinical
Ooh,
picture.
it can be so tricky.
Right, and those often tricky diagnostic nuances that can trip up even experienced clinicians.
Then we'll pivot our focus to the broad and urgent spectrum of large bowel obstruction. We'll break down its various forms, including the acute surgical urgency of, say, colonic volvulus and the non-mechanical enigma that is Ogilvie syndrome. It's really about understanding the different pathways to a similar clinical presentation.
Exactly. And finally, we'll unpack pneumatosis intestinalis, that critical radiographic sign that demands such careful interpretation, often signaling dire underlying pathology.
Yeah, seeing that on a scan always makes your heart rate go up a bit.
It does. And we'll delve into the cutting-edge techniques for intraoperative assessment of bowel viability. This is a truly crucial aspect for surgical decision-making in these complex cases, directly impacting patient outcomes.
Okay, sounds like a packed agenda.
Get ready for a thorough exploration full of clinical pearls and insights to sharpen your diagnostic and therapeutic acumen.
Colonic ischemia, the silent threat with dire consequences.
All right, let's unpack colonic ischemia first. This is a condition that, in my experience, can be incredibly deceptive.
It really can.
It's often more common than we realize, maybe especially now with our advanced imaging like CT and endoscopy increasing its recognition, right?
Yeah, I think that's true.
So for the intensivist, what's the broad picture here when we talk about its prevalence and, more importantly, its outlook?
You're right, it's a spectrum, and it truly is a chameleon. The overall mortality rate for colonic ischemia, or CI, is cited at around 12%.
Okay.
However, it's absolutely crucial to remember that these statistics frequently originate from lower-level evidence studies,
Right.
which means there can be significant variability in reporting and perhaps even an underestimation of its true impact in the high-acuity ICU setting.
So we should probably assume it's even higher in our typical ICU patient.
I think that's a safe assumption. The critical insight here is to assume a higher baseline risk in your critically ill patient population and act accordingly. This isn't a benign condition you can afford to miss.
And we see some interesting demographic factors at play, don't we? When we look
Yeah.
at who's most affected and what their prognosis might be. Are there specific patient profiles that should immediately, raise our antenna?
Absolutely. Male gender, for instance, is consistently identified as a predictor of poor prognosis in CI.
Interesting. Why is that?
Well, the precise reasons for this disparity are not yet clearly understood. Some hypotheses suggest a potential link to estrogen levels, maybe protective effects, highlighting an intriguing area for ongoing research. But the clinical takeaway is clear. Male patients with suspected CI should immediately trigger a higher level of vigilance in your assessment, regardless of the still unclear biological mechanisms. Furthermore, a systematic review involving over 3,200 patients revealed a pooled median age of 70 years.
Okay, so older population generally.
Generally, yes, but with a surprisingly wide range from 19 all the way to 98 years.
Wow, 19.
Yeah. This means age isn't a strict rule out for this condition. It's particularly notable that younger patients, defined as under 40 years, can also be affected.
Yeah.
Though perhaps with different underlying etiologies, maybe mesenteric venous issues like myointimal hyperplasia rather than typical atherosclerosis in those younger folks.
So if I'm caring for a 35-year-old male with an acute abdomen, I can't just dismiss CI because of his age. That's a vital point.
Precisely.
And when we look at specific subtypes, you mentioned the prognosis changes dramatically. What's the most dangerous distribution we need to be aware of?
Yes, and this is a critical point for intensivists. Patients with isolated right colon ischemia, or IRCI.
IRCI. Okay.
They face a significantly worse prognosis than those with non-IRCI. The mortality rates are stark. 48.4% for IRCI versus 12.1% for non-IRCI.
48%. That's huge.
It's a nearly fourfold difference, and it underscores the profound importance of identifying the precise distribution of the ischemia. If you suspect right-sided involvement, your urgency for intervention should escalate dramatically.
That's a really stark difference. It essentially sounds like a completely different disease in terms of its severity.
In many ways, it behaves like one.
And the need for surgical intervention also seems to correlate strongly with this distribution, correct?
Exactly. The risk of mortality and the frequency of surgical intervention are substantially higher for IRCI patients. We're talking 19.7% mortality and a striking 53% surgical intervention rate.
Over half need surgery.
Right. Compare that to 9.1% mortality and only 14.5% surgical intervention in the non-IRCI group.
Big difference.
Huge. Additionally, pancolonic ischemic disease affecting the entire colon shares a similarly poor prognosis and a high mortality rate of 21%. These numbers truly emphasize the gravity of the condition when it involves the right colon or the entire colon. They are not just statistics, they are direct indicators of how aggressively you need to manage these patients.
Given those grim statistics, what are the major drivers then of this poor outcome, especially in the context of critical care where every minute matters?
Well, diagnostic delay and severe comorbidities are critical worsening factors for prognosis in both IRCI and non-IRCI patients.
Right, so time is key.
Time is absolutely key. This raises an important question for us in the ICU. How can we improve early identification amidst the chaos?
Yeah.
Early recognition of patients at high risk, those with male gender, tachycardia, absence of rectal bleeding, which is counterintuitive maybe,
Mm-hmm.
peritonitis, shock, or hypotension. These should immediately trigger consideration for early endoscopy or surgery. These are the red flags.
Yeah.
Studies consistently show that early intervention is associated with a better prognosis. This emphasizes the critical, proactive role of the intensivist in rapid assessment, not just of the patient's overall stability, but also in thinking ahead about the underlying pathology and pushing for definitive diagnostics.
That distinction between the typical presentation and the real-world ICU scenario is key. Given its variable nature, how does CI typically present, and what makes it so notoriously hard to diagnose in a busy ED or ICU? It sounds like it's a master of disguise.
It absolutely is. The clinical presentation of CI is notoriously nonspecific, truly making it a diagnostic chameleon. The main features include abdominal pain, fecal urgency, and the presence of bloody diarrhea.
The classic triad.
Kind of, yeah. But while these symptoms are classic textbook descriptions, their temporal sequences are observed in only about half of cases, primarily from lower-level evidence studies.
Only half.
And there's significant variability in how these symptoms actually manifest. A patient might not have all three, or they might not appear in that exact convenient order. You really can't rely on a perfect textbook picture.
So a patient might not fit the classic textbook picture, which can easily lead to misdiagnosis, especially in a crowded ED. I'm thinking, what's the actual diagnostic accuracy like up front?
Exactly, and it's pretty sobering. A retrospective study highlighted just how elusive this diagnosis can be, concluding that CI was correctly diagnosed in only 9% of patients at the time of initial presentation.
9%. Wow.
Think about that, 9% up front. This diagnostic delay, largely driven by these atypical or nonspecific symptoms, directly contributes to a poorer prognosis for the patient. It's why an intensivist's high index of suspicion is so vital.
What about laboratory tests? Are they our reliable allies here in the same way they are for, say, sepsis or acute pancreatitis? Can we hang our hats on a specific biomarker?
Unfortunately, no. Laboratory tests for CI are also quite nonspecific, mirroring the clinical presentation. While systemic hypoperfusion, a hallmark of ischemia, can indeed lead to elevated serum lactate levels, a common red flag in critical care, and an indicator of anaerobic metabolism. A normal lactate level absolutely does not rule out full thickness damage to the bowel wall.
That's huge. Don't be reassured by a normal lactate.
Absolutely critical point for intensivists. It underscores the limitations of relying solely on routine labs to rule out severe bowel injury. You cannot be falsely reassured by a normal lactate. Other markers like elevated white blood cell count or C-reactive protein are equally nonspecific, merely indicating inflammation or stress.
So if the clinical picture and labs aren't giving us clear answers, what should we be thinking about in the differential diagnosis? What are we ruling out while we're considering CI?
In the differential diagnosis, especially in the early phases, the clinical presentation of CI can closely mimic various infectious colitis.
Right, like C. diff or E. coli.
Exactly. Patients can present with mild to severe abdominal pain, diarrhea, maybe fever, making it incredibly difficult to predict CI severity and prognosis based on clinical presentation alone. Therefore, stool examinations for ova, parasites, Clostridioides difficile, E. coli O157.H7, especially in cases of hemorrhagic colitis, and cytomegalovirus or CMV should always be considered.
So cast a wide net initially.
You have to. These are critical to differentiate as their management pathways are entirely different. This necessitates a broad workup when you're facing an acute undifferentiated colitis.
Given that challenge with clinical signs and labs, what about imaging? What's the go-to technique for CI, and what are we specifically looking for on those scans?
Okay, so for CI, computed tomography or CT with intravenous contrast is the preferred diagnostic technique.
CT with IV contrast. Got it.
It boasts an impressive positive predictive value of 98%,
Wow.
making it an indispensable, almost definitive tool in your diagnostic arsenal. This is where we often get our first definitive clues to confirm suspicion or rule out other catastrophic diagnoses.
And what are the specific CT findings that, when you see them, scream colonic ischemia to you, that make you lean in a little closer to the monitor?
Well, CT allows for precise determination of both the distribution and the severity of the disease, which, as we discussed, is crucial for prognosis.
Right, like IRCI versus non-IRCI.
Exactly. Key findings include wall thickening with signs of submucosal edema that suggests fluid accumulation within the bowel wall due to injury and capillary leak.
Okay.
You might also see irregular margins, mucosal enhancement indicating inflammation or hyperemia, and symmetric mural thickening, with or without pericolic stranding, which points to inflammatory changes in the surrounding fatty tissue.
So fat stranding too.
Yep. These subtle signs are absolutely critical to interpret correctly as they guide our understanding of the extent of the damage. For example, the halo sign or target sign due to submucosal edema is a classic finding, representing concentric layers of different densities within the bowel wall.
Are there any other imaging considerations or specific tests for broader bowel ischemia that intensivists should be aware of, especially when differentiating between types of ischemia, say small bowel versus large bowel?
Yes. While CT with IV contrast is paramount for colonic ischemia and general bowel ischemia, particularly in hemodynamically stable patients presenting with acute abdominal pain. That abdominal CT scan is the standard initial test to rule out other causes.
Okay.
However, if there's high suspicion for intestinal ischemia affecting the small bowel, or maybe more proximal large bowel, then CT angiography, CTA, or MR angiography, MRA, become the initial tests of choice.
Angiography, right, to see the vessels.
Exactly. To visualize the mesenteric vessels directly for signs of occlusion or stenosis, CTA is often preferred over MRA due to its lower cost, wider availability, and speed, all crucial factors in emergency settings where time is tissue.
Makes sense.
And it's critical that CT scans are performed without oral contrast,
Okay. Why no oral contrast?
because it can obscure bowel wall enhancement and mesenteric vessels, leading to diagnostic delays by hiding those crucial findings we just discussed. Oral contrast can create a hyperdense lumen that makes it difficult to assess mucosal integrity or subtle enhancement patterns.
Got it. So we're talking about differentiating patterns here and focusing on the vascular supply itself when intestinal ischemia is high on the differential. It sounds like a targeted approach is vital.
Exactly. Specific CT findings suggestive of acute mesenteric ischemia, which is broader than just colonic ischemia but shares some features, include pneumatosis intestinalis, which is gas within the bowel wall.
We'll come back to that one
We
later.
will. Also, portal vein gas, indicating gas in the portal venous system, an ominous sign of severe ischemia.
Very bad sign.
Very bad. Mesenteric edema and streaking of the mesentery, signaling inflammation, focal edematous bowel wall, abnormal abdominal gas patterns, and even solid organ infarction in severe, widespread cases of hypoperfusion. Angiography, whether CTA or MRA, is typically reserved for patients with a high suspicion of acute mesenteric ischemia with negative standard CT findings, or specifically in cases of non-occlusive mesenteric ischemia, NOMI.
An OMI, right, where it's spasm, not a clot.
Precisely, where it might show diffuse stenosis of the mesenteric vessels without clear occlusive lesions, indicative of severe vasoconstriction. Duplex ultrasound, while useful for detecting clots in the proximal main vessels in some settings, has a limited role here.
Why is that?
Well, its sensitivity can be significantly reduced by factors like peritoneal gas, prior abdominal surgery, or obesity. It's simply not robust enough for the acute assessment of widespread ischemia.
Beyond imaging, endoscopy seems to play a critical role in diagnosing CI. How does it fit into the picture? And what can we expect to see during colonoscopy, given that the findings can evolve over time?
Endoscopy, specifically colonoscopy, is indeed essential for both diagnosis and management of CI. The timing of colonoscopy is crucial.
Okay, timing. How soon?
It should ideally be performed within 48 hours of presentation.
48 hours.
So why 48 hours? Because this allows us to determine the disease severity and guide optimal management before the acute findings either resolve or progress irreversibly.
Makes sense.
Endoscopic findings themselves vary based on the severity of the ischemia and, importantly, the duration since the initial ischemic insult. If you wait too long, the acute signs might be gone, or the bowel might be, frankly, necrotic.
So these findings evolve over time. This means an early scope might look very different from a later one. What are we looking for in those initial hours versus later?
Exactly. Studies show that the rate of endoscopic findings actually decreases with increasing time between clinical presentation and colonoscopy.
So you might miss it if you wait too long.
You might. So if you wait too long, you might miss the acute changes that are diagnostic. Early features of CI can include segmental erythema, which is just redness in patches due to hypereocomia,
Okay.
scattered erosions, which are superficial breaks in the mucosa, atechia, those tiny pinpoint hemorrhages indicative of submucosal bleeding, more significant ulceration, and hemorrhagic nodules, essentially collections of blood in the submucosa.
Got it.
However, it's important to note that there are no unequivocally pathognomonic endoscopic findings for CI on their own. They must be interpreted in the full clinical context combined with imaging and the patient's presentation.
Are there any classification systems that intensivists or our gastroenterology consultants use to grade the severity of CI based on endoscopic findings? It sounds like having a standardized way to describe what we see would be incredibly helpful.
Absolutely. Favior's endoscopic classification provides a helpful framework, categorizing CI into 3 stages of escalating severity.
Okay, Faviers. Stage 1.
Stage 1 involves petechiae and erosions interspersed with healthy mucosa, where the ischemic damage is limited to the superficial mucosa. Visually, you might see small red spots and minor breaks in the lining, perhaps like a mild sunburn.
Okay, superficial. Stage 2.
Stage 2 progresses to deeper ulcerations, which involve the mucosa muscularis. Here, the damage goes deeper, presenting as more pronounced sores.
And Stage 3.
And Stage 3, the most severe, describes a necrotic colon due to transmural ischemic injury, which carries a very high risk of perforation and demands immediate attention. This is often characterized by dark, dusky, or frankly, black tissue.
Right. Sounds ominous. So a clear escalating scale of severity. Any other important classifications that provide more granularity?
Yes, Nikolic et al. Proposed a 4-stage classification, offering a bit more granularity and specific visual cues.
Nicholas.
Stage 1 involves patchy mucosal edema and erythema, where the lining looks swollen and red in areas.
Similar to Faviers 1.
Kind of, yeah. Stage 2 shows superficial ulceration and early pseudomembranes visually. You might see linear ulcerations along the longitudinal axis of the colon and maybe a whitish-yellow exudate forming.
Pseudomembranes.
Stage 3 presents with cyanotic or black mucosal nodules, signaling more profound and likely irreversible ischemia.
Getting worse.
And Stage 4 is characterized by widespread cyanotic mucosa with deep ulcerations, truly resembling necrotic tissue. These are visually quite distinct and indicate progressive damage, often requiring surgical intervention.
What are some key differentiating features we might spot endoscopically that help distinguish CI from other inflammatory bowel conditions, like Crohn's or UC, which can sometimes look quite similar and cause diagnostic confusion?
That's a great question. A clear demarcation of lesions, meaning a sharp border between affected and healthy tissue, is a helpful feature.
Okay, sharp borders.
Also, the single stripe sign, which refers to those linear ulcerations along the longitudinal axis of the colon we mentioned, perhaps like you'd see in Figure 2 of some textbooks, is helpful for differentiating CI from other inflammatory bowel conditions like Crohn's disease or ulcerative colitis, which tend to have more diffuse or skip lesions.
Right.
Dark purple discoloration of the colic mucosa is also a characteristic endoscopic feature highly suggestive of CI.
Purple hue.
And interestingly, the rectum is often spared in most CI patients.
Rectal sparing. Important clue.
Very important, which means that biopsies, particularly from atypical ischemia sites, play a critical diagnostic role in confirming the diagnosis and ruling out other pathologies like infectious colitis or inflammatory bowel disease.
This reminds me of the histopathology for general bowel ischemia, which really underpins what we're seeing on endoscopy and helps explain the progression of injury. Can you tell us more about those microscopic changes and how they progress from the initial insult?
Yeah, absolutely. From a histopathological perspective, the initial change in intestinal ischemia, which usually occurs within a very short time frame, like 3 to 4 hours,
That fast.
that fast, it's necrosis of the mucosal villi. This is the most sensitive part of the bowel to ischemia because the villi are metabolically highly active and sit right at the end of the capillary supply.
Makes sense.
This damage can then progress, leading to transmural, mural, or mucosal infarction, meaning the death of tissue through the entire wall, part of the wall, or just the superficial layers. The splenic flexure and rectosigmoid junction are particularly susceptible to hypoperfusion and hypoxia.
The watershed areas.
Exactly. This reflects their watershed vulnerability. Imagine two separate irrigation systems that meet in the middle. If pressure drops in either, the overlap zone is the first to suffer. This makes them prime targets for ischemia because they receive dual blood supply from the superior and inferior mesenteric arteries and are thus vulnerable to systemic hypoperfusion. Initially, the intestinal wall becomes congested, appearing edematous, friable, and hemorrhagic in response to the injury. Without intervention, bowel hemorrhage can occur within 1 to 4 days, eventually leading to intestinal gangrene and perforation due to the proliferation and translocation of enteric bacteria from the compromised lumen into the abdominal cavity.
Right, the bacteria go out.
Exactly. This progressive damage is precisely what we're trying to prevent with rapid diagnosis and intervention.
Moving to treatment then, what are the core principles for managing CI? Especially in the demanding ICU setting where you're often juggling multiple organ systems in a patient who might be, teetering on the brink.
The management of CI is highly individualized, based directly on its severity and specific clinical criteria. For mild to moderate CI, the primary approach is supportive.
Okay, supportive care first.
Right. This critically includes correcting any underlying cardiovascular abnormalities, such as ensuring adequate volume replacement to restore perfusion and address any hypovolemia.
Fluids, pressors if needed.
Absolutely. Equally important is administering broad-spectrum antibiotics to prevent bacterial translocation from the damaged bowel into the bloodstream, which can quickly lead to sepsis and further systemic deterioration.
Makes sense. Which antibiotics?
A third-generation cephalosporin, a fluoroquinolone, or an aminoglycoside are typically recommended for this purpose, aiming for coverage against enteric gram-negative bacilli and anaerobes.
What about corticosteroids and anti-inflammatory drugs? There seems to be some debate or controversy around their use in CI, and I've seen them used for other inflammatory conditions.
Yeah, this is where it gets interesting and indeed a bit controversial, but there's a very clear guideline. The American Gastroenterological Association, or AGA, guidelines generally do not recommend corticosteroids for CI,
Okay, no steroids generally.
except in cases where vasculitis is present as a clear, confirmed underlying cause.
Okay, vasculitis is different.
Right. Vasculitis-induced ischemia is a distinct entity that might respond to immunosuppression. While some recent prospective trials have looked at corticosteroids for severe or chronic CI, it's also been paradoxically reported that prednisolone, a common corticosteroid, can actually cause CI in certain patients, especially those with pre-existing vascular risk factors.
Wow, okay, good to know.
And nonsteroidal anti-inflammatory drugs, or NSAIDs, are definitively not recommended for CI treatment due to their known propensity to cause ulcerations, impair mucosal healing, and exacerbate bowel injury by reducing prostaglandin synthesis. So avoid them. Absolutely avoid NSAIDs.
Definitely avoid NSAIDs.
Got it. Are there any alternative or adjunctive therapies that have shown promise, even if the evidence is more anecdotal or limited to case reports? What are the off-label considerations we might see?
Yes, there are some intriguing reports, though not standard practice. Anecdotal evidence suggests that fatty acid enemas may help heal mucosal lesions in unresponsive CI, potentially by providing local nutrition or anti-inflammatory effects.
Fatty acid enemas. Interesting.
Yeah. Ribamidite enema, which is an amino acid analog, has also been reported to be useful for its anti-inflammatory and anti-ulcer effects, though these are not standard first-line therapies and warrant further research. These are more for chronic or persistent low-grade ischemia rather than the acute severe events we typically see in the ICU.
What about anticoagulation and antiplatelets, which are so common in other ischemic conditions like MI or stroke? Is there a role for them here?
Generally, therapeutic anticoagulation is not indicated for CI itself unless there's an underlying thrombotic disorder or maybe confirmed mesenteric venous thrombosis.
Okay.
However, prophylactic anticoagulation is strongly advised.
DVT prophylaxis. Always.
Always, especially given the hypercoagulability observed in conditions like severe sepsis or COVID-19. This hypercoagulability is thought to be related to a cytokine storm and systemic inflammation rather than a direct progression of intravascular coagulation causing colon ischemia. But the risk of clots elsewhere is still there, so DVT prophylaxis is crucial.
Makes sense. Antiplatelets.
Prophylactic antiplatelet treatment, on the other hand, does not minimize the risk of CI and is generally not recommended. Furthermore, drugs for ischemic heart disease, such as certain vasodilators or negative inotropes, should be used with extreme caution in these patients
Why is that?
because they could cause hypotensive episodes and inadvertently exacerbate the ischemia reperfusion phenomenon in the colon, making the situation critically worse by further compromising a vulnerable blood supply.
So be careful with those cardiac meds.
Very careful.
When does surgery become the answer? What are the hard criteria that screen for immediate surgical consultation in CI, indicating that medical management alone won't suffice?
Urgent surgical consultation is indicated for any patient with severe CI. This is defined by clear peritoneal signs on physical examination, things like guarding, rigidity, or rebound tenderness, which signal perforation or transmural necrosis.
Peritonitis, basically.
Exactly. Other absolute red flags include pneumatosis intestinalis or portal venous gas on imaging.
There's that pneumatosis again.
Right. Gangrene found during colonoscopy or pancolonic distribution or IRCI on imaging or colonoscopy.
Right.
These are absolute red flags that tell us these patients are highly likely to require surgical intervention for resection of non-viable bowel. In such severe cases, transfer to the intensive care unit is mandated, along with strict fasting, continuous oxygen therapy, and, of course, aggressive correction of any cardiovascular abnormalities to optimize them for the operating room.
We've talked about acute CI, which is a critical emergency, but what about the longer-term sequelae? What happens to patients who survive the initial ischemic event, and what should we be counseling them about?
Well, a non-negligible number of CI patients will unfortunately develop recurrent, chronic, or stricture disease.
Strictures, okay? How common?
Colonic ischemia strictures specifically can develop in a wide range, maybe from 0.3% up to 26% of cases.
That's a big range.
It is. The good news is that many of these strictures are asymptomatic, and quite a few can even resolve spontaneously within 12 to 24 months, so not all require intervention. This is why watchful waiting is often appropriate for asymptomatic strictures.
When do these strictures become a surgical problem? And what are the alternatives to surgery for symptomatic strictures? It sounds like a delicate balance of observation versus intervention.
Indications for surgery for chronic CI cases are quite controversial and definitely require an individualized approach. Surgery is generally indicated only for symptomatic strictures, particularly those causing partial obstruction.
So, if they're having symptoms.
Right. Which would manifest as recurrent abdominal pain, bloating, or changes in bowel habits that significantly impact quality of life. Endoscopic dilation can be an alternative to surgery for symptomatic strictures, especially for patients who are poor surgical candidates, perhaps due to multiple comorbidities that make them high risk for an operation.
Balloon dilation.
Exactly. However, it's important to note that its long-term safety and efficacy for CI strictures haven't been definitively demonstrated in robust studies. It's more commonly used to palliate malignant obstruction.
Okay.
Close follow-up is absolutely crucial for preventing recurrent rhizodes. Patients should be counseled to avoid dehydration and constipation, and to be cautious about overly aggressive treatment of hypertension, especially during illness or exercise, to maintain optimal colon perfusion. All medications should also be reviewed, particularly those known to cause or exacerbate ischemia.
Makes sense.
Finally, recurrent bacteremia or sepsis from unhealed segmental colitis areas should prompt consideration for elective segmental colon resection, as these ongoing infections can severely impact patient health and lead to chronic inflammation.
Wow, that was a lot to unpack on colonic ischemia. We covered a huge spectrum from diagnosis to long-term management.
It's a complex topic.
It really is. So, pulling together the threads on colonic ischemia for you listening, the critical takeaways are CI can be a chameleon, often tricky to diagnose early, but with a significant mortality, especially with isolated right colon ischemia or pancolonic involvement. Male gender is consistently identified as a risk factor. Labs are nonspecific, but CT with ID contrast is your key diagnostic tool, and you're looking for signs like wall thickening, edema, and mucosal enhancement. Colonoscopy within 48 hours is vital for severity assessment, using classifications like Favier's or Nicolex. Management ranges from supportive care with broad-spectrum antibiotics to urgent surgery for severe signs like peritonitis, pneumatosis, portal venous gas, or gangrene. And remember, strictures are a common chronic sequela, sometimes needing intervention, but often resolving on their own.
Bowel obstruction, a spectrum of surgical emergencies.
That deep dive into colonic ischemia really highlights how subtle and insidious bowel compromise can be. But sometimes the problem isn't about blood flow, it's about a complete roadblock. Let's pivot now to the broad, urgent spectrum of large bowel obstruction, or LBO, a clinical emergency in its own right that brings a whole new set of challenges to our ICU doors.
Yeah, LVO is definitely an emergency.
How does it typically present, and what are its core characteristics that we, as intensivists, need to immediately recognize?
LBO is truly an emergency, often accompanied by sepsis, significant dehydration, and hemodynamic compromise. These patients are sick, and they're sick quickly.
Right.
From the outset, the obstruction can be broadly classified as either structural, meaning there's a physical blockage like a tumor or stricture.
Mechanical obstruction.
Right. Or functional, which involves a motility disorder without a physical impediment.
Like Ogilvy's.
Like Ogilvy's, exactly. A crucial distinction for intensivists is whether the patient has a competent ileocecal valve.
The valve. Why is that so important?
If that valve is competent, it creates what we call a closed-loop obstruction. This turns the colon into a closed chamber where gas and fluid continue to accumulate proximally, leading to rapid and severe illness upon presentation due to escalating intraluminal pressure and a significantly heightened risk of perforation, particularly of the cecum. The cecum is the widest part and has the thinnest wall, so it goes first usually.
Okay, so competent valve, closed loop equals high perforation risk.
Got it.
What are the most common causes of LBO we see in adults, especially in the context of critical illness? I'm thinking about the differential diagnosis we're drawing up on admission.
Well, the majority of LBOs stem from neoplastic, neurogenic, inflammatory, and mechanical causes originating within the colon itself.
Okay.
However, extrinsic factors such as compression from a space-occupying tumor outside the bowel, widespread carcinomatosis, or fibroproliferative processes within the peritoneal or retroperitoneal cavities can also cause LBO by external compression.
Right.
Interestingly, historically, around the turn of the 20th century, volvulus was actually the most common cause.
Volvulus. Really?
Yeah. But over the past 100 years, malignancy has unequivocally become the leading underlying etiology in adults, accounting for an estimated 6% lifetime risk of malignant LBO.
Wow, cancer is #1 now.
By far. And it's important to note a rising incidence of colorectal cancer in individuals under 50 years of age.
Yeah, I've heard that.
And these patients often present with aggressive advanced disease in emergent settings precisely because they typically haven't undergone routine screening.
Tragic.
It is. Other less common but important causes to consider include diverticular disease, which might present with pain, fever, and a palpable mass. Various types of hernias, Spigelian, lumbar, inguinal, diaphragmatic, umbilical, ventral, and even conditions like endometriosis, which can cause extrinsic compression in women.
How do patients usually present clinically? And what are the key findings we'd pick up on our initial assessment in the ED or ICU? What are those telltale signs?
Clinically, patients with LBO typically present with colicky abdominal pain, progressive abdominal distension, sometimes quite massive, minimal, or absent flatus or bowel movements, which is a key clue.
No gas passing.
Right. And nausea and vomiting. If the ileocecal valve is incompetent, patients may decompress their large bowel into the small bowel, often leading to significant bilious vomiting.
Right.
However, and this is a critical differentiator, with a competent ileocecal valve, you'll see ongoing colonic distension, often with progressive right iliac fossa pain.
That right lower quadrant pain again.
Exactly. This right iliac fossa pain is a very ominous warning sign of impending cecal perforation, as the cecum is the thinnest part of the colon and most prone to rupture under high intraluminal pressure.
Oh.
A digital rectal examination might reveal an empty rectal vault, a palpable mass, or fresh blood, depending on the underlying cause. Imaging is absolutely vital to differentiate mechanical causes from functional issues like ileus or pseudoobstruction, and crucially, to identify any associated ischemia or necrosis. Initial management always involves aggressive bowel resuscitation and decompression.
Let's zero in on a particularly critical and dangerous cause of LBO. Colonic volvulus. This is one that always gets our attention in the ICU. What exactly is it, and why is it so immediately life-threatening?
Colonic volvulus occurs when a redundant, often mobile segment of the colon twists upon its mesentery, that fan-shaped tissue that anchors it to the abdominal wall and contains its blood supply.
Right, it twists on itself.
Exactly. This twisting leads directly to a large bowel obstruction and, more dangerously, potential ischemia as the blood supply becomes compromised, often by twisting of the mesenteric vessels. It accounts for 10% to 15% of all large bowel obstructions in the United States.
So pretty common.
Relatively, yeah, making it the third most common cause behind malignancy and diverticulitis. The most common locations for this perilous twist are the sigmoid colon, which is highly mobile and often has a long mesentery.
Sigmoid's number one.
Yep, followed by the cecum. Transverse colon and splenic flexure volvulus are rare but should always remain in the differential.
Okay.
The immediate danger arises because obstruction of the intestinal lumen occurs when torsion exceeds 180 degrees, while true vascular perfusion is critically impaired when the twist exceeds 360 degrees, leading rapidly to gangrene, bowel infarction, and perforation.
So the twist cuts off blood supply.
Cuts off blood supply, yeah.
We've seen a rising incidence of colonic volvulus, which is concerning. But what about the overall mortality trend? Is it improving with our advances in critical care, or are we still battling the same high mortality rates we've always seen?
That's a great question, and it's cautiously optimistic news. While hospitalizations for colonic volvulus increased from approximately 17,888 in 2007 to 21,715 in 2017, suggesting a rising burden of disease, inpatient mortality has actually decreased from 7.6% to 6.2% over this period.
Okay, so we're getting better at managing it.
It seems so. This is positive news and suggests improvements in both diagnostic speed and management strategies, likely reflecting better critical care support, earlier recognition, and more advanced surgical techniques available.
What are the classic signs and imaging findings that should immediately trigger a high suspicion for colonic volvulus in an unstable patient? I'm thinking about the resident who calls you at 3 a.m.
Yeah, a high level of suspicion based on presentation is absolutely essential for expedient diagnosis. On physical examination, patients often present with marked abdominal distension and tympany, that drum-like sound on percussion due to trapped gas and fluid.
Right, tympanic abdomen.
Exactly. Tenderness may or may not be present, depending on the underlying bowel compromise and whether ischemia or perforation has already occurred. Classically, a digital rectal examination may reveal an empty rectal vault, a somewhat nonspecific but suggestive finding in an obstructed patient. Laboratory findings can vary widely, from relatively normal in early stages to leukocytosis, dehydration, electrolyte derangements, or acute kidney injury, depending on the patient's overall clinical status and the duration of the obstruction. Lactic acid may or may not be elevated, as this depends on whether venous outflow is occluded, which is crucial for the development of tissue hypoxia, or if the ischemia has progressed to full-blown infarction.
What about the imaging findings specific to volvulus, especially on plain radiographs and CT, which are often the first images we get in the ICU setting? What are those visual cues that scream volvulus?
Abdominal radiographs are crucial for initial screening and can often be diagnostic. For sigmoid volvulus, classic findings include a dramatically U-shaped distended sigmoid colon, often described as an ahostral collection of gas.
Ahostral. No markings.
Right, meaning it lacks the normal haustral markings, appearing as a smooth, dilated loop rising out of the pelvis. This coffee bean or inverted U sign is a truly telltale sign.
The coffee bean sign.
Classic.
Classic. On CT, which provides far more detail, you might see the split wall sign from mesenteric fat separation due to the twisting, or the classic X marks the spot sign, which represents crossing transition points due to the twisting of the mesentery and its contained vessels.
X marks the spot. Okay.
These are critical visual cues for diagnosis and should prompt immediate surgical consultation. Think of it like looking at a twisted rope on the CT scan.
And once diagnosed, what are the overarching goals of management? What do we need to do immediately for these patients once we suspect volvulus?
Well, the overarching goals of management are evaluating colon viability, relieving the obstruction, and preventing recurrence. In parallel with diagnostic workup, immediate and aggressive resuscitation is paramount. This includes aggressive correction of electrolytes, especially potassium and sodium, and judicious vasopressor therapy as needed to stabilize hemodynamics and restore perfusion to the bowel. Broad-spectrum antibiotics are always indicated if there are any findings consistent with bowel compromise, given the high risk of bacterial translocation and sepsis. You're basically trying to optimize them for the operating room.
What if the patient is unstable, showing clear signs of peritonitis or shock? Does the management change drastically? And what's a critical surgical pearl there?
Absolutely. For unstable patients presenting with peritonitis and clear signs of ischemic necrosis or perforation, emergent surgery is indicated to resect the involved segment without delay.
Straight to the OR.
Straight to the OR. An open approach is typically preferred in this emergent setting, especially with a massively dilated and potentially compromised colon, as it allows for rapid assessment and control of contamination.
Makes sense.
A critical clinical pearl here for intensivists and surgeons alike. Colonic detorsion, meaning untwisting the bowel, should not be performed prior to resection in these unstable patients.
Do not untwist first. Why?
This is because sudden detorsion can lead to the rapid release of endotoxins, inflammatory cytokines, and potassium from the ischemic bowel into the systemic circulation.
Reperfusion injury.
Exactly, which can cause immediate and severe clinical decompensation, a phenomenon often referred to as reperfusion injury. It's a critical moment where restoring blood flow can ironically trigger a devastating systemic inflammatory response, making the patient even sicker.
Got it. Resect first, don't detorse.
Correct. Typically, only the involved segment of the sigmoid colon needs resection, and it usually doesn't require mobilization or resection of the rectum. An end colostomy, Hartmann's procedure, should be considered in patients with ongoing hemodynamic compromise or severe contamination to expedite the operation and significantly reduce the risk of anastomotic leak due to residual ischemia or severe inflammation, prioritizing patient stability over primary anastomosis.
For cecal volvulus, which is the second most common site, is the clinical picture and management similar to sigmoid volvulus? Or are there important distinctions?
Very similar, really. Cecal volvulus shares many clinical features with sigmoid volvulus, including colicky abdominal pain, tenderness to palpation, and tympany, which may be focused more in the right or mid-abdomen if peritoneal irritation exists, given the cecum's location. An empty rectal vault may also be found on DRE. Labs are nonspecific, as with other LBOs, but metabolic acidosis, leukocytosis, or electrolyte abnormalities may be present, reflecting the severity of the illness. The principles of aggressive resuscitation and emergent surgical intervention remain consistent. The key is rapid diagnosis and source control.
Let's turn to Ogilvy's syndrome now, which really mimics an obstruction but isn't mechanical. This is a common conundrum in the ICU. What defines it? And why is it so important for us as intensivists to differentiate it from a true mechanical obstruction?
Right. Acute colonic pseudoobstruction, or Ogilvy's syndrome, is characterized by acute dilatation of the colon without an anatomic lesion obstructing the flow of intestinal contents.
No blockage.
No blockage. This is the key differentiator and why it's a pseudoobstruction. It presents with all the classic signs and symptoms of a mechanical obstruction: abdominal distension, pain, obstipation. But the underlying cause is functional, often involving the cecum and right colon. The dilation can occasionally extend all the way to the rectum. It's essentially a massive paralytic ileus of the colon, often thought to be due to an imbalance in autonomic nervous system control.
What are the common triggers for Ogilvy's that we frequently see in our critical care patients? It seems to pop up in a wide variety of clinical scenarios.
It really does. Ogilvy's usually occurs in hospitalized patients, particularly those with a severe underlying illness such as sepsis, MI, severe heart failure, acute respiratory failure requiring mechanical ventilation.
So sick patients.
Very sick patients, or those post-surgery, especially after cardiac surgery, orthopedic procedures like hip fracture repair or transplantation, it's often associated with metabolic imbalances like derangements in potassium, calcium, or magnesium, or hypothyroidism.
Electrolytes again.
Yeah. And it can also be triggered by the administration of culprit medications, and this is a big one for intensivists. Think of antipsychotics, various psychotropic drugs, serotoninergic agents, and even corticosteroids, as we saw previously with colonic ischemia.
Wow, steroids again.
Yep. Neurological diseases such as Parkinsonism, stroke, and dementia, as well as retroperitoneal pathologies like malignancy or hemorrhage causing nerve irritation, are also linked. Interestingly, it's been rarely associated with infections like herpes zoster, HIV, and notably COVID-19.
COVID-2.
Yeah, in severe COVID-19 cases, the mean time from symptom onset to developing Ogilvy's was about 34 days, with a mean illness duration of 25 days, highlighting a prolonged course, perhaps related to severe inflammation or direct viral effects on the enteric nervous system.
What are the primary complications we worry about in Ogilvy's, especially given that it's not a mechanical obstruction, but it still seems to carry significant risk?
Well, in Ogilvy's, increasing colonic diameter raises tension in the colonic wall. According to Laplace's law, tension, pressure x radius, as the radius of the colon increases, the wall tension increases, even with relatively normal intraluminal pressure.
Okay.
This dramatically increases the risk of colonic ischemia and, critically, perforation. The risk of colonic perforation increases sharply when the suckle diameter exceeds 10 to 12 centimeters.
10 to 12 centimeter cecum.
Red flag.
Big red flag. And when the distension has been present for greater than 6 days, this is a crucial point for patient monitoring and clinical decision-making. However, the duration of dilation is probably even more important than the absolute diameter itself.
Duration matters more than just size.
Arguably, yes. Sustained pressure can lead to progressive ischemia and necrosis of the bowel wall, even at diameters slightly less than 10-12 centimeters if the duration is prolonged. How do we diagnose it definitively and, perhaps more importantly, how do we rule out a mechanical obstruction given the similar symptoms? What's our diagnostic algorithm?
The diagnosis is suspected in patients with abdominal distension or pain and a distended tympanitic abdomen on physical exam. The primary diagnostic goal is twofold. First, establish the diagnosis of acute intestinal pseudo-obstruction, and second, assess for complications like ischemia, perforation, or peritonitis. Crucially, we must definitively rule out other causes of colonic distension, especially a mechanical obstruction, which requires entirely different management.
What imaging modality is best for this diagnostic process, and what are we looking for on that scan?
We perform an abdominal CT scan to establish the diagnosis and definitively rule out mechanical obstruction.
CT.
CT again. On CT, you'll typically see proximal colonic dilatation, often with an intermediate transitional zone at or adjacent to the splenic flexure, and characteristically an absent structural cause of obstruction.
No tumor, no stricture, no volvulus.
Exactly. This lack of a physical blockage is the key diagnostic feature. Dilation can occasionally extend all the way to the rectum. CT also has the added advantage of demonstrating other intra-abdominal pathology that might have precipitated Ogilvy's, such as a retroperitoneal hemorrhage or significant inflammation.
Yep.
If CT isn't immediately available and there's no evidence of peritonitis, a water-soluble contrast enema can be used to rule out mechanical obstruction, as the contrast will flow freely through to the rectum.
Good alternative if needed.
Yes, but a critical point for intensivists. Colonoscopy should not be used to make the diagnosis of acute colonic pseudo-obstruction.
Do not use scope for diagnosis here.
Absolutely not. Gas insufflation during the procedure can worsen colonic dilatation and significantly increase the risk of perforation, turning a pseudo-obstruction into a real disaster. It's a therapeutic tool, maybe, but not a diagnostic one for this specific condition.
Got it. And for treatment, particularly pharmacologic options, what's our go-to in the ICU to get this colon moving again?
Okay, so for patients with Ogilvy's syndrome, assuming supportive care, fluid resuscitation, electrolyte correction, discontinuation of culprit medications, ambulation if possible, isn't resolving the issue, a key pharmacologic intervention is neostigmine.
Neostigmine, right. How does it work?
It's an acetylcholinesterase inhibitor. This drug works by increasing the concentration of acetylcholine at the neuromuscular junction, thereby stimulating colonic motility and reversing the paralytic ileus. It can resolve the pseudo-obstruction in an impressive up to 94% of cases.
Wow, 94% success. That's high.
It's very effective. The standard dose is 2 to 5 milligrams delivered by slow intravenous injection over 5 minutes to minimize side effects.
Neostigmine sounds incredibly powerful with that high success rate. But what are the critical safety considerations, especially with its known cholinergic side effects? I know this one can be tricky.
Yeah, this is a high alert medication that requires extreme vigilance, continuous monitoring of vital signs and electrocardiogram for at least 30 minutes after administration, along with continuous clinical assessment for 15 to 30 minutes, are mandatory immediately after administration.
Continuous monitoring. What?
Because of the risk of severe bradycardia, even asystole.
Cardia.
Patients should be kept supine on a bedpan to allow for immediate bowel decompression once motility returns. Critically, atropine must be immediately available at the bedside to treat potential bradycardia.
Atropine at the bedside. Non-negotiable.
Absolutely non-negotiable. It's a common and dangerous adverse effect of neostigmine, potentially necessitating rapid administration. Other cholinergic side effects include hypotension, seizures, bronchoconstriction, a major concern in asthmatics or COPD patients.
Right.
Severe nausea, vomiting, excessive salivation, diarrhea, and abdominal cramps.
A lot of side effects.
Yeah. Co-administration of glycopyrrolate, an anticholinergic agent that doesn't cross the blood-brain barrier, might reduce some of these peripheral side effects like bradycardia and bronchoconstriction. But it's still an area of ongoing study. While subcutaneous administration and continuous infusion are alternatives, further studies are needed, as continuous infusion has been associated with more bradycardic events, even if it leads to greater bowel diameter reduction. Erythromycin, given intravenously or orally, a prokinetic agent, has also been reported in case reports for acute intestinal pseudoobstruction, though responses have been inconsistent and less reliable than neostigmine.
What if medical therapy, including neostigmine and supportive care, fails to decompress the colon? What's the next step, and when does surgery become necessary for Ogilvy's?
For patients who fail initial supportive measures, maybe colonoscopic decompression if attempted for therapeutic reasons, and pharmacologic therapy with neostigmine, surgical management typically consists of stoma creation with or without bowel resection.
So surgery is the last resort.
Often, yes. The goal is to decompress the bowel. Patients with clear perforation or peritonitis, however, require urgent exploration, lavage, and drainage of the peritoneal cavity to control sepsis. The need for an extent of bowel resection, as well as the specific type of stoma, are always dictated by the patient's anatomy and overall clinical conditions, prioritizing source control and stability over an extensive high-risk procedure.
We've just navigated the intricate landscape of large bowel obstruction.
That was a lot to cover.
It was. So pulling together the threads on LBO for you listening. LBO can be mechanical or functional, and a competent ileocecal valve creates a dangerous closed-loop obstruction, significantly increasing the risk of cecal perforation. Malignancy is now the most common cause, but colonic volvulus remains a critical consideration. Volvulus involves a colonic twist, with sigmoid being most frequent. You should look for the classic U-shaped colon on X-ray, or X marks the spot on CT. Manage with resuscitation and often emergent surgery, but crucially do not detorse before resection in unstable patients to avoid rapid endotoxin release and catastrophic reperfusion injury. Ogilvy's syndrome is a pseudo-obstruction, common in critically ill patients, with perforation risk tied to cecal diameter and duration of dilation. CT is key for diagnosis to rule out mechanical causes. Avoid diagnostic colonoscopy due to the risk of worsening dilation. Neostigmine is the drug of choice, but be ready with atropine for potential bradycardia.
Beyond obstruction, pneumatosis intestinalis and intestinal viability.
Okay, let's move on to pneumatosis intestinalis, or PI. This is a radiographic finding that can be a profound red flag in critically ill patients.
Definitely a red flag.
It's one of those signs that when you see it, your mind immediately races to bowel compromise. What exactly is it, and why is it so concerning? What's it telling us?
Right. So pneumatosis intestinalis refers to the presence of gas within the wall of the small or large intestine. It's crucial to understand that PI is a sign of underlying pathology, not a primary condition itself.
It's a sign, not the disease.
Exactly. And it can indicate anything from a relatively benign finding to a life-threatening emergency, such as bowel ischemia or perforation. It has been described under many historical names like pneumatosis cystoides intestinalis, intramural gas, or pneumatosis coli. PI can also be associated with pneumoperitoneum or free air in the peritoneal cavity.
Free air. Bad sign.
Always a bad sign. Always raises immediate concerns about perforation of a hollow viscus, requiring emergent surgical exploration.
How is it classified, and what does that classification mean for us clinically in terms of patient prognosis and the urgency of management? Is there a good PI and a bad PI?
Yes, there absolutely is. PI can be classified as primary or secondary. Primary or benign causes usually result in mild abdominal symptoms, and patients can even be entirely asymptomatic, with PI resolving spontaneously, which is a relief.
Okay, so sometimes it's benign.
Sometimes. This benign form is often associated with conditions like COPD or scleroderma. However, secondary PI indicates a more serious, often life-threatening underlying condition. It frequently presents with severe peritoneal symptoms, strikingly similar to intestinal ischemia and peritonitis, such as acute abdominal pain, tenderness, and signs of sepsis.
Got it.
About 3% of PI patients experience significant complications like pneumoperitoneum, intestinal ischemia, and obstruction, making it a critical finding to investigate immediately. Your job really is to differentiate between the benign and the truly dangerous.
What are the proposed mechanisms for how gas actually gets into the bowel wall to cause PI? I've heard a couple of theories, and I'm curious which holds more weight.
Yeah, there are two main theories that attempt to explain this phenomenon: the mechanical theory and the bacterial theory.
Mechanical and bacterial.
The mechanical theory suggests that gas enters the bowel wall either through a break in the mucosal integrity or from increased intraluminal pressure, such as from conditions like asthma, severe COPD, or positive end expiratory pressure, PEEP ventilation, in intubated patients.
PEEP can cause it.
It's implicated, yeah. It can also be iatrogenic from procedures like endoscopy or recent abdominal surgery. The gas, according to this theory, may then track along mesenteric blood vessels to infiltrate the bowel wall, essentially being forced in. However, the argument against the mechanical theory is that there's an invariable absence of a gas trail directly from the mediastinum to the intestine, which you'd kind of expect if it originated in the lungs. Furthermore, some studies have found that the gas composition of the intramural cysts often differs from alveolar air, containing a mixture of hydrogen, nitrogen, and carbon dioxide, which points to a different origin.
Interesting. So what about the bacterial theory?
The bacterial theory, on the other hand, posits that gas-producing bacteria invade the compromised bowel wall and produce the gas in situ as a byproduct of their metabolism.
Bacteria making gas inside the wall.
Exactly. Given the typical patient population with secondary PI, think ischemia, necrotizing enterocolitis, the bacterial theory often seems more compelling for the severe cases we see.
What are some common associated conditions that prompt us to look specifically for PI, especially in our critically ill patient population? It sounds like the list is pretty extensive.
It really is extensive. It's imperative that a patient's history always be reviewed for underlying etiologies and risk factors for intestinal ischemia and obstruction when PI is suspected. Many diverse diseases and conditions are associated with PI, indicating its nonspecific nature but critical importance.
Like what?
These include pulmonary diseases like asthma, COPD, and emphysema, where increased intrathoracic pressure could be a factor in the mechanical theory. Autoimmune conditions such as lupus variants, polymyositis, dermatomyositis, polyarteritis nodosa, and celiac sprue can also be associated due to vasculitis or altered gut integrity.
Autoimmune links, too.
Yeah. Drug-induced causes are important. Think of alpha-glucosidase inhibitors, corticosteroids, which can both cause CI, and immunosuppression leading to infection, and even molecular-targeted therapy like bevacizumab and sunitinib used in cancer treatment, which can cause direct vascular toxicity.
Wow, cancer drugs.
Yep. Gastrointestinal issues are a large category, including IBD, diverticulitis, severe C. difficile infection, appendicitis, carcinoma, peptic ulcer disease, perforation, and necrotizing enterocolitis, especially in neonates.
Yep.
Infections like HIV, AIDS, Mycobacterium tuberculosis, and notably severe COVID-19 have also been linked.
COVID again.
In COVID-19, PI has been reported to resolve with conservative treatment of the respiratory illness, and it's speculated that bowel wall damage and altered gut microbiota during the infection could be contributing factors. Finally, iatrogenic causes, such as blunt abdominal trauma, endoscopy, and post-surgical intestinal anastomosis, also play a significant role. It's a broad and varied list, emphasizing the need for a comprehensive diagnostic approach.
How do we actually diagnose PI on imaging, and what would it actually look like to us on a plain film or a CT scan? Can you paint a picture for us?
Imaging is absolutely crucial for diagnosis. Plain abdominal radiography may show thin, linear lucencies or collections of air within the bowel wall, sometimes resembling distinct bubbles or cysts.
Linear lines of air.
Exactly. However, abdominal CT is far superior, providing much more detailed and often definitive information. On CT, you'll clearly see gas within the bowel wall, often appearing as distinct linear or bubbly lucencies. These can be circumferential or more patchy.
CT is better.
Much better. Abdominal ultrasound can also reveal PI as high-amplitude gas echoes with acoustic shadowing. To give you a verbal picture of what a plain film might look like, imagine numerous linear collections of air within the bowel wall. In a patient with ischemic bowel, that's classic PI, and it's a warning sign. You might also see gas outlining the folds of the colon.
Once PI is identified, what's the general management approach, given that it's a sign and not a disease itself? It sounds like the treatment is highly dependent on determining the underlying cause.
Exactly right. The core principle is always to treat the underlying etiology of PI, whatever that may be.
Treat the cause.
Treat the cause. This might involve simple measures like discontinuing culprit medications, as PI has been shown to resolve in all patients after stopping targeted molecular cancer chemotherapy in some reported series. For patients who develop obstructive symptoms from PI but are not surgical candidates due to high perioperative risk, successful relief of obstruction has been described using endoscopic puncture and sclerotherapy of the cysts, essentially deflating the gas bubbles.
Puncturing the cysts. Interesting.
Yeah, kind of like bumping a balloon, carefully. Admission to the medical intensive care unit is warranted if the patient becomes clinically unstable, requiring vasopressors and closer monitoring. A surgical consult is necessary for patients meeting criteria for septic shock, presence of portal venous gas, acute abdomen, or clear perforation.
Got it.
It's important to recognize that patients who are septic at the time of diagnosis have increased mortality, emphasizing the critical need for swift interprofessional collaboration and decisive action, because sepsis with PI often means severe bowel necrosis.
When we do take these critically ill patients to the OR, especially in the context of ischemia or perforation, assessing bowel viability is paramount. It's one of the most stressful parts of the case, I imagine.
It absolutely is. Gut versus no gut decisions are tough.
What are the challenges in this assessment? And what modern techniques can aid the surgical team beyond just looking at the color of the bowel?
Assessing intestinal viability intraoperatively is notoriously challenging and has traditionally relied heavily on subjective findings observed by the surgeon. Looking at the bowel's color, checking for peristalsis, feeling for arterial pulsations.
The classic signs.
The classic signs. However, studies consistently show that surgeons often lack predictive accuracy for things like anastomotic leakage based on clinical judgment alone.
So looking isn't always enough.
Unfortunately, no. This significant limitation has driven the development of more objective methods to ensure we're resecting all non-viable tissue and creating healthy anastomoses, minimizing the risk of a devastating leak.
Can you elaborate on some of these objective methods that are relevant for intensivists to understand when discussing surgical decision-making for these patients? What are the tools the surgeon uses now?
Certainly. We can categorize them by their underlying principles. First, we have spectroscopic techniques. Visible light spectroscopy, VLS. This method, often favored by its advocates, uses shallow penetrating visible light to measure bowel wall oxygenation.
VLS.
Its advantage is the ability to take point measurements on very small tissue samples, and it boasts a narrow normal range, typically a few under 3%, which is significantly tighter compared to near-infrared spectroscopy. It also doesn't require tissue contact, as the instrument corrects for uneven baselines, avoiding pressure-induced perfusion changes from a probe.
So pinpoint accuracy, no contact needed.
Right. Near-infrared spectroscopy, NIRS. In contrast to VLS, NIRS measures oxygenation using deeper penetrating near-infrared light, sampling a relatively larger tissue volume.
NIRS, deeper, wider view.
Exactly. Its normal range is wider, around a 9%. While both assess tissue oxygen saturation, their penetration depths and sampled volumes differ, making them suitable for slightly different applications or providing complementary information. NIRS gives a broader picture, while VLS is more pinpoint.
Got it. What else?
Second, and increasingly impactful, is laser fluorescence angiography, LFA. This is a sophisticated method increasingly validated for assessing intestinal microcirculation. It involves the rapid intravenous injection of a fluorescent dye, indocyanine green, ICG.
ICG, we use that for other things too.
We do. The bowel at the site of interest is then illuminated with a laser, and digital videos of the fluorescence are recorded as a function of tissue perfusion. Essentially, you see the dye perfuse the bowel in real time, highlighting areas that are well perfused versus those that are not. It's like watching a perfusion map light up.
How exactly does LFA improve outcomes, particularly when it comes to preventing complications like anastomotic leaks, which are such a major source of morbidity in these patients?
Well, LFA is highly reliable, and its measurements can be repeated after rapid clearance of ICG by hepatic uptake, allowing for multiple assessments during a single case, which is a significant advantage.
Can check again if needed.
Exactly. It has shown significant clinical impact. In one study, LFA led to extended resections of malperfused intestine in 14.2% of patients, crucially preventing non-viable bowel from being left in situ that would have otherwise led to a leak or ongoing necrosis.
So it helps resect more when needed.
Right. Conversely, it also helped avoid unnecessary resection of viable bowel in 2% of cases, preserving healthy tissue and reducing the length of bowel lost.
And saves bowel sometimes, too.
Correct. Perhaps most impressively, its use intraoperatively reduced the risk of revision due to anastomotic leakage by 60% in elective colorectal surgery, and by an even more significant 84% for hand-sewn anastomosis.
84%, that's huge.
It's a massive reduction. This robust evidence strongly suggests it could be routinely recommended in clinical practice to enhance surgical safety and patient outcomes.
Are there any limitations or caveats to using LFA that we, as intensivists, should be aware of, perhaps when interpreting a surgeon's decision based on LFA?
Yes, there are a few. The contents of the intestine, like stool or blood, can interfere with fluorescence readings, making interpretation challenging in some situations.
Okay.
Crucially, the precise limiting LFA values that unequivocally represent irreversible necrosis are not yet clearly defined, meaning it's still a tool to aid judgment rather than a definitive cutoff that removes all clinical interpretation.
Still needs clinical correlation.
Absolutely. Also, measurements can be position dependent, and it's not always applicable for assessing colorectal anastomosis situated very deep in the minor pelvis, where visualization can be an issue.
Makes sense. Any other methods?
Yeah, other objective methods that can be used include Doppler ultrasound. This technique assesses blood supply adequacy, for example, at the enterostomy resection margin by detecting blood flow. It's quick and simple.
Doppler. Familiar.
Pulse oximetry. Intraoperative pulse oximetry can help determine intestinal viability by measuring tissue oxygen saturation, similar to how we use it for peripheral oxygenation.
Put a pulse ox on the bowel.
Essentially, yes. Specialized probes exist. Tonometry. This method involves measuring intramucosal pH, PII, which can be an early and sensitive indicator of tissue ischemia, as anaerobic metabolism produces lactic acid and lowers pH.
Intramucosal pH.
Microdialysis. This advanced technique can monitor bowel ischemia by measuring metabolic markers in the interstitial fluid, offering real-time insights into tissue metabolism and signs of distress before overt necrosis.
Microdialysis. More research-based.
Still largely research-based, but moving towards clinical application. And dielectric parameter measurement, an experimental method used to estimate intestinal viability, though it's less commonly applied clinically at present.
What about assessing the viability of a newly created stoma? This is a critical postoperative consideration for us as intensivists, as stoma complications can be devastating.
Oh, stoma viability is absolutely critical. Necrosis is a very important and serious complication, observed in around 8.7% of cases in audit.
Nearly 9%.
Yay!
That's high.
It is. Insufficient perfusion and ischemia of the resected bowel end are key predisposing factors. While subjective findings, color, bleeding, often guide this assessment, objective intraoperative evaluation could potentially diminish the incidence of stoma ischemia and necrosis. Doppler ultrasound, visible light spectroscopy, which detected a normal oxygenation value of 77.6 mena 6.8 in established colostomy stomas, and orthogonal polarization spectral imaging, OPS, have been used.
Okay.
Interestingly, OPS studies comparing sublingual and stoma microcirculation found no initial correlation between intestinal and sublingual blood flow, or between intestinal and systemic hemodynamic parameters in abdominal sepsis patients.
No correlation. So checking under the tongue doesn't tell you about the stoma.
Apparently not reliably, at least initially in sepsis. This suggests that intestinal microcirculation cannot always be reliably judged from other microcirculatory beds or systemic parameters, highlighting the profound importance of direct, objective assessment of the stoma itself. You can't assume a good systemic perfusion equals good stoma perfusion.
Fascinating. Good to know. We've truly gone deep into pneumatosis intestinalis and the crucial art of assessing bowel viability in the OR.
Yeah, critical stuff.
So, pulling together the threads on this section for you listening, PI is gas in the bowel wall, a radiographic sign of underlying pathology, which can be either benign or severely life-threatening.
Yeah.
Always hunt for the underlying cause. It could be pulmonary, infectious like COVID-19, drug-induced, or iatrogenic.
Mhm.
Imaging, especially CT, is key for diagnosis, showing linear or bubbly lucencies.
In the OR, surgeons are moving beyond subjective assessment to objective techniques like laser fluorescence angiography with indocyanine green, visible light spectroscopy, and near-infrared spectroscopy to confidently determine bowel viability and reduce complications like anastomotic leaks. This is especially vital for ensuring stoma viability postoperatively.
Comprehensive management and interprofessional collaboration, the critical care nexus.
Okay, across all these complex and high-stakes conditions, colonic ischemia, colonic volvulus, Ogilvie syndrome, and even the presence of pneumatosis intestinalis, initial patient stabilization in the ICU is paramount. Absolutely. First things first.
It's where we lay the groundwork for any further intervention. What are the non-negotiables for intensivists in those crucial first hours?
Regardless of the specific bowel emergency, the immediate priorities are always hemodynamic stabilization and aggressive resuscitation. This means prompt correction of any electrolyte derangements, especially potassium and calcium, which can impact cardiac function. It also involves judicious volume replacement to address hypoperfusion and dehydration, guided by dynamic preload indicators.
Right, dynamic measures, not just static CVP.
Exactly. And critically, the early use of vasopressors as needed to support blood pressure and ensure adequate organ perfusion, titrating to mean arterial pressure goals. Broad-spectrum antibiotics are critical from the outset, particularly if there's any suspicion of bowel compromise, perforation, or sepsis to prevent bacterial translocation from the gut and mitigate a systemic inflammatory response. You're buying time and optimizing the patient for definitive management.
What about specific drug considerations beyond just broad-spectrum antibiotics for resuscitation, particularly in the context of mesenteric ischemia, where blood flow is the core issue?
Yeah, good question. Papaverine, for example, administered through an angiographic catheter, can be used for all arterial forms of acute mesenteric ischemia, or AMI, and non-occlusive mesenteric ischemia, or NOMMI.
Opavarine infusion.
Right. Due to its mechanism of relaxing vessel vasospasm and improving blood flow, it's a vasodilator. However, a crucial clinical pearl here is that papaverine infusion should not be used simultaneously with heparin due to an increased risk of papaverine precipitation.
Ah, okay. Papaverine and heparin don't mix.
They precipitate, yeah, which could render both drugs ineffective or cause complications. For embolic AMI, pharmacomechanical thrombolysis is recommended within 8 hours of symptom initiation in selected patients, typically those without bowel necrosis or signs of peritonitis, which are absolute contraindications.
Lytics for mesenteric clot.
Sometimes, yes. Recent studies favor newer agents like retiplas or tenecteplase over alteplase due to a lower risk of non-intracranial bleeding. Following initial clot management, the immediate initiation of heparin is vital to prevent additional clot formation and propagation, and conversion to oral warfarin, continued for at least 6 months, is always indicated for long-term prevention of recurrence, especially in patients with atrial fibrillation or other embolic sources.
When does surgery become the definitive answer for these conditions? And what are the key surgical considerations and potential pitfalls for our patients in critical care? We know these are high-risk operations.
Surgery is often urgently required for large bowel obstruction, and it carries a significant mortality rate exceeding 10%, which is far higher than what we see in elective colorectal surgery.
10% mortality. That's
Yeah.
high.
It is. This immediately tells you about the acuity and underlying patient fragility. The majority of patients requiring surgery for these acute bowel emergencies are already categorized as high risk due to their underlying critical illness, and therefore require a consultant-delivered care and almost invariably ICU admission postoperatively.
Need ICU post-op.
Almost always. Prompt recognition of patient deterioration, signs of sepsis, and impending perforation is absolutely vital, as surgery may be required within a matter of hours for surgical source control of sepsis or to prevent that catastrophic impending perforation. Time is truly muscle here, or rather, bowel.
What are the different surgical approaches or interventions for these severe bowel pathologies? It sounds like there's a spectrum of options.
Well, surgical management may involve bowel resection, where the diseased segment is removed, creation of a stoma to divert fecal contents, or sometimes a bypass procedure. In acute mesenteric arterial occlusion, interestingly, endovascular intervention can be as effective as traditional open surgical approaches in selected cases.
Endovascular options for mesenteric occlusion.
Yeah. Endovascular options include pharmacologic or mechanical thrombectomy. Mechanical thrombectomy involves accessing the superior mesenteric artery, usually via the femoral or brachial artery, and directly aspirating the thrombus with a specialized catheter. Catheter-directed thrombolysis is indicated for distal mesenteric embolization or if there's incomplete aspiration embolectomy targeting smaller or residual clots.
And what about the open surgical options when endovascular approaches aren't suitable or have failed? What does that procedure entail?
Open superior mesenteric artery embolectomy remains a good option when open surgical intervention is indicated. This involves a midline abdominal incision, direct visualization and palpation of the proximal SMA, and then extraction of the clot using a Fogarty embolectomy catheter threaded through a transverse arteriotomy in the vessel.
The Fogarty catheter.
Right. If reperfusion remains unsuccessful despite these efforts, a mesenteric bypass may be necessary. Although SMA revascularization can be performed in several ways, superior mesenteric artery bypass is a common method in acute mesenteric arterial occlusion, which effectively perfuses blood from an inflow vessel, such as the iliac artery or aorta, to the distal side of the occlusion lesion, restoring critical blood flow.
What about second-look procedures, and when are they necessary? I know this is a concept that's often applied to abdominal catastrophes.
Yeah, rarely. Following initial exploration or colonic resection for ischemia, a second look operation, either open or laparoscopic, should be performed within 12 to 24 hours.
Go back in 12, 24 hours later.
Right. The rationale is to reassess the viability of the remaining bowel, ensuring that all non-viable tissue has truly been removed, and to check the integrity of any newly created anastomoses. This prevents leaving behind compromised bowel that could later perforate or leak.
Makes sense. Check your work.
Essentially. In some cases, leaving the abdomen open, known as an open abdomen, may be necessary if primary closure would lead to increased intra-abdominal pressure, abdominal compartment syndrome, and it also conveniently facilitates that planned second-look procedure by allowing easier reentry.
Let's discuss colonic stenting, specifically in the context of malignant obstruction. What's its role, and what are the associated risks, particularly for oncological outcomes?
Colonic stenting is often used as a bridge to surgery for malignant obstruction, with reported technical success rates of 97.5% and clinical alleviation of obstruction at 97%.
So it works well technically.
Very well technically, making it highly effective at relieving acute symptoms and decompressing the bowel. However, it's not without risks, including perforation of the bowel wall and the potential for dissemination of malignancy, which is a significant concern for oncological outcomes.
The risk of spreading the cancer.
That's the concern. Some studies have suggested stenting is an independent risk factor for perineural invasion, although this may correlate with the severity of the obstruction itself rather than being solely induced by the stent. Meta-analyses have shown higher perineural and lymphatic invasion and higher recurrence rates with stenting compared to emergent stoma formation.
Worse cancer outcomes, maybe.
Potentially, yes, although one meta-analysis did find lower 90-day mortality in the colostomy group, suggesting maybe better short-term outcomes with diversion first.
Okay, so it's controversial.
It is. Current recommendations for malignant obstruction post-stenting include 2 cycles of chemotherapy with fluorosil, leucovorin, and oxaliplatin before operative intervention.
Chemo before surgery after stenting.
Right. To address any theoretical cancer dissemination risk and downstage the tumor, if feasible.
These conditions, by their very nature, can lead to a cascade of severe complications. Can you list the major ones that we as intensivists should always be vigilant for? Because they are often what define the patient's trajectory.
Absolutely. The complications of untreated or advanced bowel ischemia and obstruction are indeed severe and often life-threatening. They include bowel infarction and subsequent bowel perforation, which is a catastrophic surgical emergency leading to peritonitis.
Infarction and perforation.
Have it. The development of gangrenous and necrotic bowel requiring extensive resection. Sepsis, which can rapidly progress to septic shock with its associated high mortality.
Sepsis and shock. Big ones.
Endotoxemia with bacterial translocation, where bacterial products from the compromised gut enter the bloodstream, fueling systemic inflammation. Toxic megacolon, particularly in cases of severe colitis, where the colon dilates massively and can perforate.
Toxic megacolon.
Multiple organ failure, MOF, a common devastating outcome in severe sepsis and prolonged ischemia. Fibrosis, leading to chronic strictures, which can cause recurrent obstructive symptoms.
Strictures again.
Fistula formation, abnormal connections between bowel segments or other organs leading to chronic issues. And as we discussed earlier with CI, colonic stricture formation as a long-term sequela. These complications highlight precisely why prompt diagnosis and decisive intervention are absolutely critical for patient survival and recovery, and why the intensivist's role is so central.
It's clear that managing these complex bowel emergencies requires a true team effort. Who are the essential players in this interprofessional approach that we, as intensivists, need to be collaborating with seamlessly?
Managing large bowel obstruction, bowel ischemia, or pneumatosis intestinalis unequivocally demands a highly coordinated interprofessional team. Key members include clinicians. This broad category encompasses surgeons general, colorectal, vascular surgeons for specific interventions like revascularization, gastroenterologists for diagnostic endoscopy and medical management of conditions like pseudo-obstruction, and oncologists if malignancy is involved as the underlying cause and for long-term planning.
Surgeons, GI, oncology, check.
Radiologists. They are central to interpreting imaging studies, identifying the obstruction, ischemia, or PI, and often guiding interventional procedures like angiographic infusions.
Radiology is key.
Intensivists. We are crucial for critical care admission, managing hemodynamic instability, treating sepsis, and addressing multi-organ failure, acting as the central coordinator of care.
That's us.
Interventional radiologists. They play a vital role for procedures like papaverine infusion or thrombolytics in mesenteric ischemia, offering minimally invasive options.
Eye docs.
Nurses and advanced practitioners. They are absolutely vital for ongoing monitoring, meticulous fluid resuscitation, precise medication administration, and crucial patient education and family communication.
Couldn't do without them.
No way. Pharmacists. Essential for identifying offending drugs that might have contributed to the condition, optimizing medication therapy, including antibiotic regimens and pain management, and advising on dangerous drug interactions, such as between papaverine and heparin.
Pharmacists, critical for med safety.
Dietitians. They are involved in diet modification post-treatment, especially in conditions like pneumatosis intestinalis that might require elemental diets to promote healing and reduce gas production.
Dietitians, too. Okay. So what's the ultimate key to success for this diverse and highly skilled team? What pulls it all together?
Coordinated and transparent communication among all healthcare team members is the absolute cornerstone.
Communication.
It isn't just about sharing information, it's about shared understanding and immediate action. This ensures prompt recognition, accurate diagnosis, and the swift implementation of appropriate evidence-based management strategies, ultimately improving patient outcomes and significantly limiting morbidity and mortality. It's a dynamic, interconnected system.
Finally, as intensivists, our role extends beyond the acute phase of treatment to comprehensive patient education, even for preventing recurrence. What's important for patients and their families to know once they're stable and preparing for discharge to prevent them from coming back through our doors.
Patient education and their compliance with treatment are crucial, even for preventing recurrence of these severe conditions. In the initial phases, patients should be explicitly informed about the possible ways these diseases can present, what symptoms to look for, such as persistent abdominal pain, distension, or changes in bowel habits.
Tell them what to watch for.
Exactly. Understanding these signs and symptoms promptly can be the most critical factor in their future care, as early and timely intervention is the cornerstone of successful management. Non-adherence to treatment plans and necessary lifestyle modifications can lead to severe consequences, including recurrence, readmission with septic shock, and tragically, even death. Long-term lifestyle modifications, such as adhering to an elemental diet composed of highly digestible formulas, can be crucial to promote absorption and reduce gas production in the intestines for conditions like pneumatosis intestinalis. Patients should also be educated on avoiding dehydration and constipation, which can predispose to these issues, and to regularly review all their medications with their primary care provider, especially those previously implicated in bowel ischemia, to maintain optimal colon perfusion and prevent future episodes. It's about empowering them to be active participants in their long-term health. End of chapter mega recap plus flashcard bullet list.
We've covered a vast and incredibly important landscape today, from the nuances of colonic ischemia to the intricacies of bowel obstructions and the critical sign of pneumatosis intestinalis. It's a lot of information, but each piece is vital for critical care practice, directly impacting patient survival and recovery.
Indeed. It's a lot to keep straight. Let's try to distill the most crucial takeaways for you, the intensivist, to keep at your fingertips, perhaps as mental flashcards for your next challenging case.
Yeah, a quick reference would be great.
Okay, here's your flashcard summary, focusing on the high-yield, actionable insights. Colonic ischemia, CI, presentation. Often nonspecific, a real diagnostic chameleon. You need high clinical suspicion, especially in your critically ill patients. Prognosis. Remember, male gender, isolated right colon ischemia, IRCI, and pancolonic involvement mean a significantly worse prognosis. IRCI has roughly 4x higher mortality than non-IRCI. Big difference. Diagnosis. Labs are generally nonspecific. Remember, lactate can be normal despite full thickness injury. CT with IV contrast is your preferred test. PPV 98%. Look for wall thickening, submucosal edema, that halo target sign, irregular margins, mucosal enhancement, and pericolic stranding. Endoscopy. Crucial within 48 hours for severity and extent assessment. Use Fabier's 3 stages or Nicolic's 4 stages classifications. Look for those linear ulcerations, single stripe sign, and clear demarcation. Remember, rectal sparing is common. Management. Supportive care is key. Fluids, pressors, fixed electrolytes. Broad spectrum antibiotics are mandatory. Corticosteroids are not routine unless it's vasculitis. Prophylactic anticoagulation is advised. NSAIDs are absolutely contraindicated. Surgical consult. Get one urgently for peritoneal signs, pneumatosis, portal venous gas, gangrene on scope, or pancolonic IRCI. Long term, strictures are common, up to 26%, but often resolve spontaneously. Surgery is usually only for symptomatic strictures. Counsel your patients on hydration, constipation, and medication review. Large bowel obstruction, LBO, types. Think structural, mechanical versus functional, like Ogilvy's. Key point. A competent ileocecal valve creates a dangerous closed loop with high risk of cecal perforation. Causes. Malignancy is now the most common cause in adults, and it's rising in the under 50s. Volvulus is next. Volvulus, sigmoid that's the twisting upon the mesentery causing obstruction ischemia. Mortality has thankfully decreased to around 6.2%. Signs: marked abdominal distension, tympany, maybe an empty rectal vault. Imaging. On X-ray, look for the U-shaped loop sigmoid or the coffee bean sign. On CT, look for the split wall sign or the X marks the spot. Management: immediate resuscitation plus emergent surgery. Critically, do not detorse before resection in unstable patients due to the risk of reperfusion, injury, endotoxin release. Consider an end colostomy for unstable patients. Acute colonic pseudoobstruction, Ogilvy syndrome. This is that acute massive colonic dilatation without a mechanical cause, often seen in critically ill or post-op patients. Risks. Perforation risk really increases with cecal diameter 10-12 centimeters, and if the duration is 6 days. Remember, duration matters too. Diagnosis. Abdominal CT is preferred, shows proximal dilation, but importantly, no structural cause. Avoid diagnostic colonoscopy due to the risk of worsening dilation. Treatment. Supportive care first. Neostigmin, 2 to 5 milligram IV over 5 minutes is your drug of choice, but atropine must be at the bedside for bradycardia risk. Erythromycin is an alternative. Surgery is for failure or perforation. Pneumatosis intestinalis, PI definition, simply gas in the bowel wall. Remember, it's a critical sign, not a primary disease itself. Classification. Think primary, often benign, versus secondary, serious, often linked with ischemia peritonitis. Etiologies. The list is broad. Think pulmonary, COPD, PEEP, autoimmune, drug-induced, steroids, certain cancer drugs, infections, C. diff, COVID-19, iatrogenic causes, trauma, endoscopy. Diagnosis, imaging is key. Plain film might show linear bubbly lucencies, but CT offers superior detail. Ultrasound can show it too. Management. Always treat the underlying etiology. Get a surgical consult for septic shock, portal venous gas, acute abdomen, or perforation. Intestinal viability assessment, intraoperative. Remember, traditional methods like looking at color or peristalsis are subjective and have limited accuracy. Objective techniques are key. Visible light spectroscopy, VLS, and near-infrared spectroscopy, NIRS, measure tissue oxygenation, laser fluorescence angiography, LFA, with indocyanine green, ICG. This assesses microperfusion in real time and has been shown to significantly reduce anastomotic leaks, 60-84% reduction. It's repeatable during the case. Stoma viability. Also crucial to assess adequate blood supply directly to reduce necrosis risk. You can't reliably judge stoma perfusion from systemic parameters alone. Overall management principles. Prompt resuscitation is fundamental. Aggressive hemodynamic support, fix electrolytes, get broad spectrum antibiotics on board early. Consider papaverine for mesenteric ischemia, but remember the heparin interaction. Imaging. CTC Tamer are your initial go-to imaging choices, guided by your clinical suspicion. Surgical consultation. Get it early and often for high-risk patients. Think about second-look procedures in relevant cases. Colonic stenting can be a bridge for malignant obstruction, but be aware of risks like perforation and potential cancer dissemination. Complications. Always be vigilant for infarction, perforation, gangrene, sepsis shock, endotoxemia, toxic megacolon, MOF, strictures, and fistulas. Multidisciplinary approach. This is essential. Your team includes surgeons, intensivists, radiologists, gastroenterologists, IR, nurses, pharmacists, dietitians. Coordinated communication is absolutely the cornerstone. Patient education. This is crucial for deterrence and preventing recurrence. Focus on hydration, constipation, medication review, and recognizing warning symptoms. Patient education.
We've explored the critical distinctions and overlapping challenges of these acute abdominal pathologies in quite some depth. What stands out to you as the ultimate takeaway for intensivists navigating these high-stakes situations in their daily practice?
You know, what's truly fascinating here is the recurring, undeniable theme woven through every condition we discussed. In all these scenarios, from the subtle presentation of colonic ischemia to the dramatic twists of a volvulus and the enigmatic nature of pseudo-obstruction, the path to a better outcome hinges on the same core principles.
Which are?
An unwavering, proactive clinical suspicion, coupled with rapid, targeted diagnostic imaging and seamless, decisive, multidisciplinary collaboration for timely, definitive intervention. This isn't about memorizing every rare cause. It's really about recognizing the patterns of severity and acting swiftly.
Right, suspicion, imaging, teamwork, action.
Exactly, and this raises an important question for your daily practice, something to think about. In your next patient presenting with an undifferentiated acute abdomen, beyond the initial labs and vitals, what specific historical detail or physical exam finding would most prompt you to pivot your diagnostic thinking towards one of these particular bowel emergencies, compelling you to dig deeper and act faster rather than simply observe?